recently we performed another suturing. This is we named outside anal needle relaxing technique. You know, suture using as a steward after EID, and then once we pull back the needle from the lower rectum to the outside, and then tight the closure defect and tight strong. You know, it's very shortened procedure time. It's around 20 minutes. So, and recently, this is the paper from the Netherlands. This is the results of EID for deep submucosal invasive cancer, a 3 years follow-up study. This study, including 177 submucosal deep invasion cancer using EID. And surprisingly, 94% unblocked resection achieved, and R0 resection is 82%. And it's divided into the 3 types after confirmation of histology, and they reported the highest submucosal invasive cancer, which is poorly differentiated or disseminated into the lymphatic canal or vessel invasion or budding positive. So that they reported is some EID may be an alternative to radical surgery for the patient with a low and medium risk patient. But Ichimasa sensei, he's working under Professor Kido. They mentioned impact of EID of subsequent to surgery, and anatomical indication for EID is we require more debate to establish this EID in the lecture. And then the recently combination therapy with ESD with chemotherapy for advanced cancer is also reported. And in this case is 75 years old male, and has had multiple liver metastasis. But I performed the colonoscopy, the very 2 centimeters advanced small cancer identified in the sigmoid column. But the patient is has liver metastasis, but the chemotherapy is very effective for the patient. So we discussed the surgery doctor. We performed EID, full thickness resection for this advanced cancer. Unfortunately, next day the population is opening, but we applied clipping and closure completely. And then after the FOFOX 6 and some kind of chemotherapy, the patient survived many years. And this is the site of the full thickness section. This is just scar. And so that the patient not bleeding or not abdominal discomfort during chemotherapy. So I think this is one option. And my friend, Min Chai sensei from Shanghai, China, reported watch and wait after therapy, after the neoadjuvant chemotherapy. So they performing in this study, the lower cancer, lower rectal cancer, T2, clinical T2 or T3 was targeted. And 28 patients received the chemotherapy. And then, after chemotherapy, they performed the full thickness resection for this site and confirmed the histology. And mostly 78% T0 cancer is gone or T1 cancer still existed. So that this patient completely rejected after the chemotherapy, so that they watch and wait. The only 21% of the patient still remaining the cancer as a T2 decidal cancer, so that they received some additional surgery. This is a watch and wait strategy using chemotherapy, so that in the future maybe chemotherapy, chemoradiation therapy for the rectal region, and then we perform the fluid resection for the remaining or decidal tumor. It's available, one of the options alternative to the surgery. So the endoscopic resection beyond the depth alone, why does it matter? So depth alone is not enough to decide the treatment. So we should move focusing on a real oncology benefit for the patient. And so I know still the surgical treatment is very standard role. But anyway, EID or fluid resection for the lower rectal cancer is an option, especially for the patient with a high risk for surgery or aging, more than 80 years old or some older patient. And future, this is robotic surgery. You know, this is a Hong Kong company developed already the robotic platform for the ESD. So actually, I performed this robotic machine platform, very easy to operate. This is two arms